everyone. It's great to be here. This is my first time being part of one of the learning labs, so I'm very interested to be part of this. And as was mentioned earlier, my role is mainly as a researcher, and engaging policymakers isn't something that's set out necessarily as part of the research objectives, but it's something that we do to varying degrees. And at this point, I wanted to share an experience of a recent study that we'd conducted with the National Tuberculosis Control Program of Pakistan. And for various reasons that I'll discuss going forward, in this particular experience, we engaged them being the main TB policymaker in the country early on in the process and throughout the process. And that's led to a very different relationship and a lot more ownership of the results by the policymaker. So I'm going to share my experiences of why that happened a little bit. So moving on to my first slide, before I jump into the specifics of what we did, I wanted to touch upon the fact that even when we're discussing the concept of engaging policymakers, there's quite a divided opinion amongst researchers about whether that's part of the role of the research team and how important it is to do that. There's one group that would argue that researchers' role is just purely to do the study, put the results out there, and let the wider community decide whether the results are important and what they want to do with them. Whereas other researchers feel very strongly that part of their role is to form policy recommendations and then advocate for them. So there's quite a divide. And also from the point of view of career progress, usually as part of research, there's more focus on publications and less on the impact that might change going forward. But often then researchers have to decide for themselves whether they feel that one of their goals should be to engage policymakers or whether they feel that it should be just a more neutral role. So as I mentioned, I'd like to share an experience about a study we conducted with the Pakistan TB Control Program. The way this started out was that the Pakistan National TB Control Program had a budget through the Global Fund for operational research, and they asked the London School to help them design a study and run it, specifically because they had some resource allocation questions that they wanted some evidence to help them make those decisions. In this case, it was quite a broad scope because while they wanted to do the research within multi-drug resistant TB, the specific research question in that wasn't defined. So we had some room to discuss different options and start the engagement process from that point, which I'll discuss going forward. As I mentioned, the framework that I'm using and the main difference that I found with this experience and others that I've been involved in is that we engaged the National TB Control Program, who were the main policymakers for our study, right from the start and then throughout the steps that we were taking. And in contrast, in previous experiences, it's often right at the dissemination stage that policymakers are approached and engaged in, and we go up to them with a set of results and tell them what we'd like them to do with it, but before then haven't really been engaging them in what we've been doing. So in this process, we engaged the policymaker right from the start, from identifying the research question down to questionnaire design, data collection, and then analysis. And we're still getting to the dissemination stage. On my next slide, talk about how we engage them in identifying the research question, and also throughout I've put in some quotes that I've heard people saying about their experiences of when researchers don't engage the policymakers. So, for example, if people who are involved in policy setting, either at the hospital level or the national level, are not involved in defining the research question, often we have, as researchers, have great papers coming out, but when they look at these papers, they feel that it's an issue that's quite disconnected from the main issues that they're concerned about. So therefore it's really important to make sure that the areas of focus for the policymakers are captured within the research question. What we did for this piece of work, as I mentioned, we had a very broad scope. So before we jumped into identifying research questions, we took a step back and understood the current challenges and resource allocation dilemmas that were facing the National TB Control Program. And then we followed a sort of hybrid approach. As I mentioned, they did want our help in identifying a research question, so we didn't just leave it completely up to them, but equally we didn't sit together as a group of researchers in London and then come up with a perfect research question and send it to them and say, this is what you must do. What we did was sort of a middle path where we came up with a set of potential research questions, loosely defined, and got an idea from the NTP which ones they were most interested in. So it was interactive from in that process as well. It turned out that the research question we ended up focusing on was whether the use of internationally procured quality assured drugs is justified because they are more costly, and the NTP is not sure about whether the additional costs are justified by improvement in patient outcomes. So in essence, the question that we zoomed in on was whether there's a difference in patient outcomes, multi-drug resistant TB patient outcomes, when they're treated using locally procured drugs versus internationally procured drugs. What we did next, and once we had the research question, was to design our questionnaire. Now again, what I often hear when the policymakers, hospital management aren't engaged in the questionnaire design process, the feedback that we get at the end of the process is often that some important factor has been left out. And if you hear that right at the end, when you've gone with your set of results, there's very, very little one can do about that. So, examples of factors just to illustrate this is, I've noticed that in some settings, ethnicity is very important. In others, it's not. In other settings, the role of the private sector is very important. In others, it's not. In some settings, HIV is a very important factor for TB. In others, the prevalence is low. So it's quite important to know which specific factors, even within a city, are important, and make sure those are captured. So what we did for our questionnaire is to come up with a draft and then sit down with both the program managers that were funding the research and also staff at the key TB hospitals, and go through each of the questions with them, get their feedback on whether anything had been left out, and also get their feedback on how best to frame the answers, what answer categories there should be, and making sure that we're not leaving out anything in an answer option either, so that by the end of it, they really felt like they understood what pieces of information we're going to be collecting in the questionnaire. Then moving on to the actual data collection process, what goes wrong when the people on the ground aren't engaged is that they feel that they can't really trust the information. Factors that have been included aren't necessarily accurately recorded at the source, and so as researchers, we've gone in and seen something written down on a piece of paper and just taken it on face value, but people working on the ground realize that probably isn't a very reliable piece of information to include as a factor in a study. And an example that we came about in this study was data on comorbidities associated with TB. So while there's a section in the patient records on recording a comorbidity such as diabetes, in practice, when we gained the trust of the hospital staff that we were working with, it transpired that they didn't have the facilities or the funds to actually be testing patients. So if a patient was a known diabetic, then it was recorded, and if they weren't known diabetic, then that space was left blank. And if we hadn't made the effort to engage them and just use that information, we would have come up with an artificially low prevalence of, for example, diabetes in our population. So it's important that we knew that, and we didn't pay as much attention and put too much weighting on that particular variable, because we knew then that the information wasn't completely and accurately recorded in the actual patient records. What we did do to make sure that our data collection process had the confidence of the people that we would then be presenting our results to was firstly to hire and train staff from the hospitals that we are working in. And we followed a process whereby we asked them, we paid them to work after their shifts were over. And the benefit of this was that these individuals then were trusted by the hospital staff that they were working with. So discussions about, which variables are more reliable and complete happened more openly. And also that there wasn't this sense of an outsider coming into their hospitals and going through all their paperwork. So it made the process work smoothly on a day-to-day basis. And also at the end, because those people had been recommended from within the hospitals themselves, the end users had more confidence in the data that we had collected. Lastly, if we move on to the analysis stage and what we how we made a strategy to engage policymakers. So this is one that I feel quite strongly about, and I've realized through experience that often, even when we have a great paper and it results in a great publication, the results don't necessarily make the same sense to policymakers working in country as the way that it does to trained researchers. And often we forget, as we become more and more advanced and learn new techniques for statistical analyses and whatnot, we go into more complex methods of research, and we often forget that policymakers don't have research background. They're often medically qualified, but they don't necessarily have PhDs, which means that they have a great understanding of certain things, but if the research is presented in a very technically complex way, their confidence in interpreting and then sort of sharing those results within their circles is lowered. What we did in this particular study was to firstly make sure that the endpoints that we selected were relevant to the stakeholders. We realized that different types of end users had different endpoints that they were interested in. So clinicians, for example, when we discussed what they'd like to see as endpoints for the studies, they wanted to find out whether using locally procured drugs or internationally procured drugs had an impact on patient-specific outcomes, such as whether patients had improved weight gain in one of the two groups, or whether there were more side effects in one of the two groups. So clinician end users were more interested in patient-specific outcomes, whereas the program was more interested in how long it took for patients to become non-infectious, so how long it took them to go from being positive to negative on sputum culture, because that has an impact on spread of infection. So they were thinking more from a macro point of view, and similarly they were interested in proportions of patients defaulting. So we made sure that endpoints that were relevant to all the different types of end users were included. The other thing that we did was also we made a conscious effort to present the results in a way that was easily accessible to our end users. So, for example, in addition to having time to culture conversion as one of the outcomes that we presented, we also presented percentages of patients going from positive to negative on culture at, say, 3 months after treatment and 6 months after treatment, because that was something that doctors felt was useful in assessing, how long they would expect a patient to take to become culture negative. So we presented the same sort of findings in 2 or 3 different ways, so that different types of end users could access that information and use it in their daily practice. And as you see from my sort of last bullet point, come across the fact that regression coefficients, odds ratios, in practice often don't make much sense. What does that actually mean for an individual patient or a group of patients? So we obviously put those into the papers that we're writing, but make sure that when we're presenting to our end users, translated them into things that they could actually understand and relate to their daily practice. Coming back to this then and just summarizing, as I mentioned, for me, the reason that this process has been a lot more collaborative is because we engaged the policymakers and end users from the beginning, what was insightful for myself was that there are important roles that end users can play throughout the research process, and their role shouldn't just be confined to being the people that take the research results and then go away and do something with them, because actually a lot of the input that we received on the questionnaire design, on what sort of factors we should focus on and what sort of factors we shouldn't focus on because the data isn't accurately recorded, really did inform and improve our study design. And equally for the analysis, it helps us make sure that we included a wider set of endpoints than perhaps we would have come up with purely by ourselves. So having that engagement from the beginning has resulted in a very different feeling at the end of this process. As I mentioned, we still haven't got to the dissemination stage where writing up the research, but what I've found strikingly different in this process is that now when we're applying for conferences, it doesn't really make that much of a difference whether it's me presenting the data or whether it's my colleagues at the National TB Control Program, because they too have a deep understanding of what the results show, and they too feel confident being able to answer questions about the research. So that to me is it's really great, because there's been capacity building, and equally it means that conversations about this research are happening in forums where the research team isn't involved, so there's a much wider spread, whereas in other situations where the policymakers are a little bit unsure of what exactly the research is showing, or they don't really feel that the research question is that interesting, it ends up not really going much further than the meetings that the researchers themselves set up and push for. So I'm hoping that this more collaborative process means that the research takes on a life of its own, and it spreads within the end user forum without it being pushed as much from the researcher end.
I thought it was very interesting that you actually had the opportunity to go through this process. One of the observations that I've made is that frequently the structures of research are such that the research question and even the design and all of that has to be predetermined prior to, securing the money, and that actually interferes with the opportunities to kind of leave open what is the most important question. Obviously, there's ways to get around that, but I just wondered if you would comment on that, how and why the donor in this case was open to, this kind of process where they left the question undecided in the beginning.
No, I absolutely agree. This is an unusual situation, and almost turned into an opportunity, because a lot of the other research projects, as you say, things are well defined from the beginning, and one doesn't have the chance to engage so much. And because in this particular case we did have that opportunity, I was able to feel a difference in the outcomes in terms of ownership. So this is definitely not the usual case. I think the difference here was, yes, that the funding was channeled to the National TB Control Program. So the people who are controlling the funding were also the end users, and that's why the decision laid with them, and that's what made this one an unusual one. But I think it links to something that I was discussing briefly with Annie, in that often there is an overlap between the funders and the end users, or even the researchers and the end users. So where there is that overlap, it's useful to involve them. But yes, in this case, it happened that the NTP had been left with a scope that had multi-drug resistant TB as defined, but within that they could decide which policy question was most pertinent. And in fact, they wanted some help from us in even identifying what to focus on, because I think they had so many different competing questions floating around that they wanted to sort of help us to help them zoom in on one and then frame it as a research question.
Can you please explain whether the recommendations that came out of the study were accepted and implemented by the policymakers? And you also noted at the beginning that you had that little controversial findings in brackets. Perhaps you could comment on a little bit about what you are finding.
Yeah, sure. As I also mentioned, so the stage that we're at right now is we've just come to the end of the analysis phase, and we're writing up. So as far as the recommendations, we're still, they're coming out, but it's still sort of hot off the press. So I think it's fair to say that they're being accepted, but it's too soon for them to have implemented because we're still at the analysis stage. In brief, what we found was that that locally procured drugs by the hospitals that are treating multi-drug resistant TB patients were as effective. There was no superiority shown from using internationally procured drugs. So that was sort of going against the general hypothesis, which was that having procuring drugs through an international quality assurance process would result in the drugs that are coming being of better quality and therefore having better patient outcomes. And the reason I think why we found this was that the hospitals that were treating MDR patients were following their own quality assurance procedures. So even though there are a lot of substandard and counterfeit local drugs circulating, which is the main concern and the main reason that these international drugs are favored, when hospitals were able to go through their own quality assurance procedure, go to trusted manufacturers, the drugs that they procured locally ended up being just as effective or not less effective than the ones that were coming through the more expensive international quality assurance process. So that is slightly controversial because obviously a lot of money is spent on these processes involving getting drugs from international sources. And therefore it really is important that the policymakers are on board and they understand the process that we've followed and they have confidence in these results, because in cases where the results are not what one would expect, it's even more important than to be able to go back and say that we included all the factors that everyone suggested and we collected data using local recommended staff so that there's less room for that, for holes to be poked into the research.
We have another comment from Frida Bear, and she again says, first of all, thank you very much for the presentation. It sounds very much like best practice. And then she goes on to say that coming as she does from a commercial background, they always had to engage the clients at the start since they were commissioning the study. Thereafter, it became important to keep a level of distance from them in order to prevent them from forcing the results or forcing the findings into a desired result. And she asked whether or not those kinds of concerns were relevant in any way in this case.
Yeah, that's a good question. I think, as I'd mentioned, the second slide, this is one of the reasons that some, groups of scientists are less comfortable engaging so much and then being part of a process of advocacy, because they feel that can sometimes bias the results or impact them in a way that perhaps wouldn't have happened if the researchers worked in isolation. So, I think that is a valid concern. In this particular instance, the sorts of feedback we were taking that I described was a little bit more specific. It was more around what factors to include in questionnaires and how to capture it. And the reason we didn't really find any sort of forcing of the results, because in this case it was the National TB Control Program that actually they genuinely wanted to know the answer to this question. So for them there wasn't a strong leaning either way. If it was turning out that internationally procured drugs were more effective, then they would have to find the funding to go and procure them. Equally, if locally drugs were as effective, then there's less of a cost burden on them, and they can go with the local sources. But I think in this case, the commissioner of the study really just wanted to know the answer and didn't have a particular answer they were looking for. So there was less of a concern. But where the body commissioning the study has a vested interest in what the answer is, then yes, I think it is important to keep a level of distance, but perhaps still find some areas to take input, such as questionnaire design, if it's something that they have more knowledge about. So I think it's just finding the balance between getting their input in areas that the researcher might not be as familiar with, versus taking so much input that the direction of the research or the results changes.
They're just very interesting. They definitely sound like the right client for this type of approach.
Yeah, it is, and I suppose it sort of brings in the point that, who should be commissioning research. I think it's a really important question, because you don't want to end up, letting the engagement process derail the actual study.
The next question that came through the chat room is from Sarah Cohen, and actually she makes a really good point. She wants to know whether or not your commitment to engaging the researchers caused any delays at different stages, and sort of how you manage that.
It's actually involving the policymakers rather than the researchers.
For us, we did complete things on time, so we didn't feel like there was a delay. But when I think about it, if we'd, for example, done it just completely on our own as researchers and not engaged with the various stakeholders, then I'm sure it would have gone a lot faster, because, as I said, in each of the stages it did take longer, but I think in a valuable way. So, for example, if we just, the members of the team from the London School had just sat down and come up with a research question, what we would have done is we'd gone through the literature and narrowed down just onto one question and then just started. Whereas what we did was, as I mentioned, come up with a couple of questions and send them for review. So it probably did, add on a week or two to the process. But, I think at coming to the end of the process, I'm not sure if I would call that a delay so much as a pretty integral part of it. And again, I fully understand that it varies from policymaker to policymaker, because some of them are a bit slower, they're really busy. And I also feel that there's a relationship between how interested they are in the research and how much they're going to respond, which I suppose is just human nature. So I think getting them interested in identifying the research question meant that for future stages they were quicker to respond, because they liked the question. It was one that they'd chosen. So I feel that they've actually been quite eager in following up, and were really enthusiastic about seeing what the answer was to this sort of burning question they had.
Hi, this is Richard from Grassroots Soccer. I was just wondering, when you're involving the policymakers early, how closely you tie the trial to the results. So when you bring them in, you clearly define that success for this program will be 95% adherence, and at that point we'll go to scale. Anything below, we won't. And I'm just wondering how early and how specific you have those conversations.
In this case, because our recommendations or our findings were going to be just more around whether a particular set of drugs is more effective. So we didn't have those conversations, and I think in this case it would really depend on the end user's own criteria for if there was, for example, if there was a benefit shown, then they would have their own criteria for deciding, for example, what the additional costs of international drugs would be and how that weighs up against the additional benefit. Now, in this case, because there wasn't a clear benefit shown, we didn't, we haven't got to those sort of questions. But as I said, in this, I think those sort of decisions about what level of results need to be shown before a decision is taken, we didn't have those discussions, and I think usually it's something that the policymaker might decide, but without the researcher. I'm happy to know what others think, because it's an interesting idea to actually discuss that up front and to say that, if our research shows X, Y, Z, will that lead to a policy, or does it need to show, X, Y, Z times 2 before it'll make a policy impact? I don't know if people have tried discussing that up front.
This is Annie Holmes from Strive, and Mishal and I were discussing some of the issues that her presentation raised, because she gave this presentation at the London School a couple of weeks ago, which is when we asked her to share it more widely. And one of the things I found really interesting was that there's quite a range of end users that she's looking at, so that the process didn't only involve policymakers. And sometimes when we try and prepare from the beginning of a study to ensure that this information is going to be usable, of course it's important to engage policymakers and have that as one of the objectives and goals of your theory of change. But there are so many other people or groups or institutions that you need to consider. So I thought it was really interesting the kinds of people that you involved as researchers and whose opinions you sought and insight you sought along the way amongst people who work at the sort of more at the clinic level or health services definition level. And I wondered if, as people make parallels with their own work, if you have questions or ideas about how this sort of approach would apply to your work.
I can just elaborate a little bit on that, if it's helpful. So an example from the TB world that sort of brings this point home is, I remember there was a lot of research and a lot of meetings that took place to discuss whether 3 specimens or 2 specimens are required to diagnose a case of TB. And the original definition was that out of 3 specimens, 2 should be positive in order for the case to be confirmed. And then after a lot of international research, and the definition was changed to 1 positive specimen out of 2. So from a pure research and a publications point of view, the point was made and the policy was set at an international level. But then there was a delay, quite a long delay at least within Pakistan, for it to first become national policy. But then even once it had become national policy, so the national policy makers had accepted a change in the definition to diagnose a TB case, at the hospital level, they were still taking 3 specimens. They still wanted two of them to be positive to confirm a case. So there's policymakers even at a micro level, because the sort of the head, the chief TB doctor in a large TB hospital is often the more relevant policymaker, because they're deciding what's actually happening on the ground. And even though the national policymakers technically have sort of a jurisdiction, what happens on a day-to-day basis in the hospital is the decision of the hospital staff. So they are important policymakers in a sense as well.